Hi, everyone. My name is Wesley Ingram, and I am the Programs Manager for NAMI Delaware. Before we start, I just want to remind everyone of this. You are not alone. If anything that we discussed today is overwhelming for you, please reach out. Scrolling at the bottom here are crisis support options, which are 988, which you can call, text, or even chat online at 988lifeline.org. And the Delaware Hope Line for emotional support at um, 8, 8, 833-946-733. If you're not in crisis but interested in more information or resources, NAMI Delaware does have a helpline which can be called during our regular business hours at 888-427-2643. Today, we have a special guest speaker to talk about the impacts of stigma against mental health and the current research around interventions that help. So, our speaker is Dr. Valeria Earnshaw, an associate professor in human development and family science at the University of Delaware. Thanks so much, Dr. Earnshaw. I'm going to pull up your slides and let you take over.
Great. And thank you so much for that introduction, Wes. I want to maybe recognize that experiences of stigma and talking about stigma and discrimination is distressing, even for folks like me who have been studying it now for over a decade. And so I really appreciate the recognition that there could be content in the talk that could be distressing, and that's my alarm telling me to come join this call. But I appreciate the recognition, that there could be distressing content and the pointing folks in the direction of resources. So thank you so much. And I'd also like to thank the great folks over at NAMI for the invitation to join you this afternoon or this evening, and for getting this all organized, especially to Annie Sleece and Jen Jankowski. So I've very much been looking forward to joining you. Okay, so today I am going to start with an overview of stigma. We're going to do stigma definitions, and we're going to talk about how stigma is generally associated or related to different types of health and well-being outcomes. And then I'm going to summarize some research findings on stigma. And I'm going to warn here just a little bit that much of my expertise or my research focuses on stigma associated with substance use disorders specifically. So that's a bit of the content that I'm going to review, but I have supplemented, or I've added to this presentation some of the research findings about mental illness overall. So I hope that we'll get a nice flavor of both, and then I'll be happy to just talk about it or, field questions at the end of the presentation. And then I'm going to close this out with some intervention approaches, and I'll use that bar at the top of the slides to orient us as to where we are within our talk. Okay, so starting with our overview of stigma, our definition of stigma has evolved quite a bit from when a sociologist named Goffman first introduced it in the 1960s. So this is a recent definition from the Oxford Handbook of Stigma, Discrimination, and Health, so very official. The authors define stigma as a social construct. So let's break down sort of each component of this definition. So social constructs are basically ideas or concepts that are created by society. So I really want to emphasize that there's really nothing innate about them. There's nothing innate about the ideas that are behind stigma. And then these authors further define stigma as an expression of social power. And this is a really important part of the stigma definition. So social power is the ability to influence or to control others. And power is the backbone of stigma. It's really what creates stigma and reinforces stigma. They also note that stigma involves identifying a socially conferred mark that distinguishes individuals who bear this mark from others. So marks can be identities, they can be social categories, they can be illnesses, anything from gender, race, mental illness, substance use. These all count as socially conferred marks within the context of this definition. And important to this part of our definition is the idea that people are marked, maybe they're given a label, and then they are distinguished or separated based on that mark. So there's this idea that social groups are created as sort of us versus them. And then finally, theorists emphasize that stigma portrays them as deviating from normality and meriting devaluation, which sounds terrible, this part, but basically what this part of the definition is getting at is that people with these marks are seen as different somehow than others and also deserving of poor treatment or discrimination. So when I'm using this term stigma today, I'm really referring to this broad social process that depends on power. It involves separating people with certain characteristics from others and results in discrimination and poor treatment. So stigma has been characterized as a fundamental cause of health inequities. And so I'd like to just take a moment to think about, how does stigma impact health? So the process linking stigma with health outcomes are similar across a wide range of stigmatized statuses. So this means that the process is going to be similar if we're talking about stigma associated with mental illness or substance use disorders today, but it would also be similar if we were considering race or LGBT stigma or another form of stigma. So I'm sharing here just a really broad, cross-cutting conceptual framework with you. So it starts with this social construct of stigma that we've been talking about, or this social process. And then it acknowledges that a social process is sort of an abstract idea. And so it thinks about how stigma is manifested, which means that how is it expressed or experienced within our structures and within individual people. And these are called stigma manifestations. Now, these are a really good place for us to focus our attention because they are both measurable and they are changeable. So broad social processes like stigma are difficult to quantify, to put a number to, but we can quantify stigma that is occurring within our structures or within people or individuals. We can use our surveys to do that. And we want to measure it sometimes to figure out how bad or how strong it is, how exactly it's impacting outcomes that we care about, and whether our interventions to change it are actually working. And I also want to emphasize, though, that these stigma manifestations that I'm going to talk about are also changeable. So we have evidence-based intervention tools that we know can either reduce them or sort of protect people from them. So essentially, these stigma manifestations are excellent intervention targets. And we have tools to measure stigma and interventions to change stigma for these manifestations at multiple social ecological levels. They're not popping up very nicely on the screen, but we are focused on people who have experienced mental illness or substance use disorder in this talk, but that lighter blue circle is supposed to say community members, and that might include family members, coworkers, healthcare providers who interact with individuals with substance use disorders or mental illness. And these folks may direct stigma towards those folks with substance use disorder or mental illness. And then we have stigma at the structural level. So let's take a moment to define stigma at all of these levels. So first, thinking about stigma at the structural level, this is defined as societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. So that definition is a little bit of a mouthful, but you can think about policies here, cultural norms, and we're going to come back to different examples of this as we go along. Among community members, so if we're thinking about family, employers, healthcare workers, they may endorse prejudice, which sometimes I say lives in the heart. This involves negative emotions and feelings like maybe disgust or pity. They may also experience stereotypes. Sometimes I say this lives in the head or in the brain. It's how people think. These are group-based beliefs that are often applied to individuals. And then we have discrimination, which is poor treatment of individuals. And then if we finally think about people who may have experienced or are experiencing a substance use disorder or mental illness, these folks may experience internalized or self-stigma. So they may endorse all these negative beliefs and feelings associated with the stigma and think that they're true and maybe apply them to the self. They may experience enacted or experienced stigma, which is just discrimination from other people in the past or the present. So this might be receiving poor care in a medical setting. And they may also anticipate stigma, which refers to expectations of discrimination in the future, like expecting to receive poor care in a medical setting. So if we return to our figure, these experiences of stigma that we've just introduced, so these stigma manifestations, they're related to a suite of mediating mechanisms, which is just a scientific way to say that there are processes that link our experiences of stigma with our health outcomes. So these experiences of stigma can undermine our access to resources. So for example, they prevent people from accessing treatment or employment. They compound social isolation, and they can lead to psychological responses like stress or avoidant coping. And then together, these different processes, which here are called mediating mechanisms, all have downward impacts on mental, physical, and behavioral health. So they can undermine our health. Now, before we transition into some of our research findings, I just would like to acknowledge that folks who have experienced mental illness or substance use disorders are a super diverse group. So intersectionality theory, which is really rooted in Black feminist thought, highlights that all people live with a range of intersecting social statuses. So these represent both dimensions of marginalization or oppression, as well as of privilege. And this framework draws our attention to the social structural environment. It really emphasized the importance of thinking about interlocking systems of oppression, much like a bird cage, that's sort of built to keep people in or down. So in this metaphor, substance use disorder stigma might be one bar, mental illness stigma might be another bar, but sexism and racism and LGBT stigma might be other bars. So these all sort of come together to create a bird cage that might surround an individual. So for the purposes of this presentation, I think it's particularly important to consider that these unique intersections both shape individuals' experiences of stigma and the ways in which stigma may impact their health outcomes. So for example, a young Black woman's experience of stigma related to her mental illness might be quite different from an older white man's experience of stigma. Okay, so we're now going to dig into the literature a little bit, and we're going to look at some of the research findings that we do have on stigma and these different health outcomes. And I'm going to summarize some of our findings on stigma at each of these social ecological levels that we've introduced. So if we start with the structural level, and if we think about substance use disorders, the war on drugs is one of the most commonly cited examples of structural stigma in this context. So these policies are critiqued as treating people with substance use disorders as criminals rather than as people with chronic illnesses, and they lead to increased risks of incarceration, which can impact people's health and recovery. An additional example of structural stigma, though, would include barriers that exist to prescribing or accessing evidence-based treatments. So let's think about this just for a moment in relation to that concept of intersectionality that we just talked about. So racial residential segregation is one of our most well-studied forms of structural racism. So it's a legacy of redlining, of Jim Crow laws, of slavery. And Godal and colleagues did this really interesting study where they found that indicators of racial residential segregation were associated with access to methadone and buprenorphine. So it's a little hard to see here, but the graph on the left is showing access to methadone and the graph on the right is showing access to buprenorphine. And they essentially found that facilities at the time, this was a few years ago, but facilities providing methadone were more likely to be in segregated African American and Latinx counties, whereas facilities providing buprenorphine were more likely to be in segregated white counties. So essentially they found that where one lives, which is fundamentally shaped by residential racial segregation, which is this powerful form of structural racism, shapes access to the type of medications for opioid use disorder that people can access across the entire United States. Folks in the mental health field have identified lots of examples of mental illness stigma at the structural level, and in particular, these include or some of the ones that really stand out to me are critiques that our mental health treatment system is deprioritized in comparison to the physical health treatment system. So it's been critiqued as having inadequate funding, fragmented bureaucracy, not being well integrated into primary care. This is part of the reason why, the wonderful advocacy work of the folks at NAMI is so important to keep lifting this up in terms of importance on our statewide and national agenda. And folks have also identified policies that affect people with mental illness as stigmatizing as well. So these include lack of privacy protections, like policies that permit the disclosure of mental health information in certain circumstances, and policies that are perceived or described as paternalistic in nature or don't treat people as full autonomous adults. And again, I just want to recognize the great work that NAMI Delaware does in terms of, identifying some of these policies and doing great, advocacy work down in Dover to get them changed when they do identify them. So it's been a real pleasure since moving to Delaware to learn more about the great work that they're doing on the structural and other fronts. At the level of the individual perceiver, so now if we think about people who don't necessarily have a substance use disorder or a mental illness themselves, researchers who have studied prejudice, so that affective or feelings component of stigma, the part that I said lives in the heart, have found that prejudice towards people with substance use disorders is characterized as contempt and experienced as feelings that express a sort of moral outrage, like anger, disgust, hate, and blame. And then prejudice towards folks with mental illness more generally is also characterized by fear and by anger. Stereotypes, that belief component, or the part that I said, joked sort of like lives in the brain or lives in our heads, are characterized by perceptions that people with substance use disorders are dangerous, unpredictable, responsible for their condition, and not capable of decision making. And again, there's some overlap with stereotypes about people with mental illness, which also include that they're not competent or capable of decision making, and also that there's an element of dangerousness. And then in terms of discrimination, research has identified and characterized discrimination towards both people with substance use disorder and mental illness in a wide range of contexts. So everything from healthcare to employment to housing to friendships to family settings. So everywhere we look, we tend to see evidence of discrimination. I just want to take a moment to demonstrate the prevalence of the stigma. So just how much of it is out there in the US. So these data were collected in 2018 from a nationally representative survey in conjunction with our general social survey. And what you can see here is that at the time, a majority of US adults felt that people with opioid and alcohol use disorders were likely to be violent towards others, which would be a stereotype, and that they're unwilling to spend an evening with, unwilling to have someone marry into their family, and unwilling to work closely with someone with an opioid or alcohol use disorder. Now, these rates are all higher than when people considered interacting with someone with depression, which is there in yellow. But the rates when people were thinking about interacting with someone with depression were also bad. So we've got 30% of folks thinking that people with depression are likely to be violent and are unwilling to work with people with depression. And over 40% don't want people with depression marrying into their family. So we've got a lot of work still left to do to change these thoughts, feelings, and behaviors among our community members within the general public. Luckily, we've got some solutions, which we'll come back to at the end of the presentation. Stigma within healthcare settings can have tremendous implications for health. So I just want to take a moment to highlight some findings that are relevant to providers here. And this is more from the substance use disorder space, which is getting increasing attention in healthcare circles, including within Delaware. So I just kind of want to mention this briefly. So a systematic review that was recently published reviewed evidence across several studies focused on providers and found evidence that providers endorse stereotypes about people with substance use disorders. These are treatment providers. That implicit or unconscious prejudice is associated with greater intentions to leave one's job, which has implications for job turnover and the stability of our treatment settings. And providers who endorse more stereotypes and prejudice may be providing lower quality care. And in the qualitative work that we've done, we have been particularly worried about stigma in healthcare settings. So people in our studies describe pretty striking examples of stigma, especially in emergency medical settings or other settings where they might need some type of pain management, like if they're having a surgery. So this was a quote from the mother who was in one of our studies. Actually, her daughter had experienced an overdose. And the doctor just discharged her with this note saying, stop taking drugs because they will kill you or hurt others. And the mother, rightly so, identified this as a really inappropriate discharge note for someone who has a life-threatening chronic illness. She should have gotten a referral to treatment. Okay, so I'm going to wrap up our research with targets of stigma. So we're going to focus here on people who are at risk of living with or in recovery from a substance use disorder or a mental illness. And I'd like to kind of back up just a moment here and highlight that we have a good amount of research that people who experience more stigma engage in more substance use. So I've been focused specifically on stigma experienced by people with substance use disorders in this talk, but I'd like to emphasize that stigma is a risk factor for substance use among people experiencing many other forms of stigma. So here are just a few examples from the LGBTQ and race stigma literatures. And I'm sorry, those little boxes are supposed to be arrows, and you're going to see a lot of those. So just substitute that in your mind. But this research suggests that people who experience enacted stigma, so poor treatment from others based on their sexual orientation, gender identity, or race or ethnicity, cope with these experiences through substance use, including alcohol, tobacco, marijuana, and other illicit substances. Stigma in this research is related to the greater likelihood of use and more frequent or disordered use of our substances. And then also among people who are in treatment for substance use disorders, we see some evidence that stigma is associated with continued substance use. We see very similar trends when we think about mental health. So there is a very robust body of literature suggesting that stigma is associated with pretty much anything: race, LGBTQ identities or expressions, disability, substance use disorder, even really any kind of stigma that you could think about, it's associated with worse mental health. So again, here are some examples from that racism and LGBTQ literatures. We see associations between experiences of stigma with anxiety and depression symptoms, self-esteem, burnout, PTSD, psychosis, and distress. And then also we see that among people who have been diagnosed with a mental illness, that when they experience more stigma, it's associated with greater mental illness symptom severity. So again, what I want to emphasize here is that with both substance use and mental illness, we're seeing a cycle where stigma associated with these other characteristics like sexual orientation, gender identity, race, other things can lead to substance use and mental illness. And then stigma associated with substance use and mental illness can lead to more substance use and mental health. So it's a pretty, I guess it's not a full cycle, but it's a pretty, I actually think about it like a snowball that's like gaining snow as it rolls down the hill. So it's gaining more negative impacts. So it's getting, it's snowballing, it's getting worse. Okay, so turning to the association between stigma and treatment outcomes, our qualitative literature is very consistent. When we talk to people about their experiences, they tell us that when they internalize and anticipate more stigma, they're less likely to start treatment. And also when they get negative feedback from other people, that it impacts their treatment engagement. We also have evidence that substance use disorder stigma is related to worse treatment-related outcomes, including more treatment-seeking delays, less engagement, and higher rates of dropout. And when we turn over to the mental illness stigma literature, we see similar findings. So Patrick Corrigan has written quite a bit about how stigma undermines engagement in treatment for mental illness. He has shown that people are less likely to engage in treatment when they're worried about how others will think of them. So that's anticipated stigma. And he's also shown that people who have stereotypes about what people with mental illness are like, and who feel that they don't fit those stereotypes, are less likely to engage in treatment. So let's say someone has a stereotype that people with mental illness are dangerous and they don't really think that they themselves are dangerous. They may not recognize their own symptoms of mental illness and then not get treatment for that. And then other studies have shown that people who perceive more mental illness stigma in their environments are less adherent to their treatment and medication plans, including, for as an example, antidepressant medication. Okay, so I'm going to wrap us up with a few examples of interventions. And I'll start off by saying, unfortunately, we don't have one silver bullet to stop stigma associated with substance use disorders, mental illness, or really any other characteristic. But we do have many tools in our stigma intervention toolkit. So in other words, we've developed a sense of strategies that do work to decrease stigma. We have tools to address stigma at the structural level among our community members and among folks with substance use disorders or mental illness. And I'm going to spotlight just a few of these for us. So one intervention tool is to aim for policy change at the federal and state levels. So we can aim to repeal stigmatizing policies. We've had powerful calls for this in the context of substance use disorders, and we've also had some really nice success stories, I think, in Delaware. Theoretically, repealing these policies should lead to better outcomes for folks experiencing stigma. And we do have examples of that happening. So this is an example from the LGBTQ stigma literature. And so research found that in the year following the legalization of same-sex marriage in Massachusetts, that the mental health of sexual minority men in Massachusetts improved. So there's a lot of opportunity for change here. We have a lot of policies that we could work on to remove stigma that hopefully would result in better health outcomes for folks living with stigma or experiencing stigma. All right, I'm actually going to skip this one, but happy to come back to it, for the sake of time. I want to highlight one of our most powerful ways to address stigma among community members, including members of the general population, healthcare providers, and others, is through contact. Contact can either happen in person, like when people interact and talk with each other, or vicariously through the media, such as TV, the radio, podcasts, or books. Research suggests that contact leads to increased empathy and perspective taking with stigmatized individuals. It also leads to more knowledge, which can lead people to question those stereotypes, and reduced anxiety about interacting with stigmatized individuals in the future. And then in turn, this all filters down to lower prejudice or improve feelings towards stigmatized individuals. And we know that lower prejudice paired with reduced stereotypes can lower the likelihood of discrimination, which is often our end goal. I want to highlight one intervention tool that we can all do, which is paying attention to our language. This is actually a nice evidence-based way to change stigma among community members and the general public. So research does show that language can spread stereotypes. So for example, individuals described as substance abusers are seen as deserving of blame and punishment, as unlikely to benefit from treatment. But research also shows that language that is scientifically accurate and people first, like saying a person with a substance use disorder or a person experiencing depression, has been shown to promote perceptions that substance use disorders and mental illness are chronic yet treatable health conditions. So I like this one because I think it makes me think that all of us have an opportunity to reduce stigma every time we're talking about substance use disorders or mental illness. We can also address stigma among targets, among people who may be experiencing substance use disorders or mental illness. I often think about bolstering resilience resources for stigmatized people. These include modifiable strength-based characteristics that may buffer or protect folks from the negative impact of stigma on health outcomes. Examples are social support interventions, adaptive coping interventions. And the idea here is that stigma may take a while to change. We still have pronounced racism and sexism here in the US. So it's important to think about how to protect people from it while we're all sort of working towards that main goal of dismantling it at the structural and social levels. So we do have other tools, and the trick is to figure out how to use our tools or implement them in ways that make them most effective. So we do have some evidence on how to do this. We know that multi-component interventions that use more than one stigma reduction tool at a time appear to be more effective. So we might want to pair contact with an education intervention to reduce stigma. Multi-level interventions that address stigma at both the structural and individual levels and among community members and among folks experiencing stigma appear to be more effective. And then longitudinal interventions that use our stigma reduction tools over time appear to be more effective. So we don't want to go in, with one 45-minute assembly and, expect that stigma is going to be solved on the other side of that. It's a good start, but we really want to be thinking about what we can do over time. So I'm going to highlight just one evidence-based intervention for you that sort of packages some of these intervention tools. So this was featured in a report from the National Academies of Sciences, Engineering, and Medicine. So it's kind of a best practice stigma intervention. It was called Time to Change. It was a large-scale program designed to reduce stigma towards people with mental health problems in the UK, in England specifically. It was implemented starting in 2008, and it actually ran all the way up to 2021. So it's pretty good if we're talking about longitudinal interventions. It featured intervention tools including education, contact, and activism. It targeted several specific stakeholders like medical students, teachers, and employers. And evaluations have showed promising results, including improvements in intended behaviors like being willing to work with, live with, or continue to have a relationship with someone with a mental health problem. So all these different indicators of discrimination seem to look better over time. And it also showed reduced internalized stigma among people with mental illness. So I want to leave you with this one because although stigma is a big problem, I think that we do have some nice examples of community-led efforts that have done a nice job of reducing stigma. And hopefully this can give us some food for thought for different strategies that we might be able to think about here in Delaware. Okay, so that's my 30 minutes for slides. So Wes, I'm not sure if you wanted to come back and help me with the questions or if I should just dig in.
Hi, thank you so much for that presentation, Dr. Earnshaw. That was really awesome.
Please call me Valerie.
Valerie.
Yes, thanks.
We do have one question
Great.
from Jennifer Rose.
Mm.
Asks, how can we address stigmatizing language from family during holiday events? I know you touched on
Oh,
language,
yeah.
and, but I don't know if you had any specific tips or any other resources that we might want to throw out there, put in the chat.
Jennifer, thank you so much for this question. It's such a good one, and I struggle with this one in my family as well. So my low-key intervention is just to use the language, right? And so, if someone is talking to me about a substance abuser and they're saying, this is a substance abuser, blah, 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 I'll kind of just like repeat back to them what they said, but I'll sub out substance use disorder. So I'll say, oh, okay, so it sounds like that person's experiencing a substance use disorder. And so, people will hear that. Sometimes I'll do it a couple times that the conversation is playing out, but that's my really low touch intervention for language change. Or indirect intervention. And that's the one that I'll roll out, especially if I think I don't have a receptive audience, someone who I have a lot of family members who, think that that they don't want their language to be critiqued. Maybe who does? But a more direct approach is just to say, hey, to call attention to it and say, I recently became aware, or I didn't know until, to kind of model the change in yourself can be one way of doing it if you want to. And I have done that approach, like, for example, the use of transgendered versus transgender. I had used the word transgendered in an email, and my colleague so kindly and beautifully said, oh, I saw you use transgendered. I just want to draw your attention to, most folks prefer the term transgender, and kind of explained to me why transgendered, didn't make sense, which I was really grateful for, that they told me, that they invited me to use that term. So if you feel like you're working with someone who might be more open to language change, or might be more open to thinking about that with you, then that's the approach that I take, is to say, hey, I noticed that you're using the term substance abuser. Just want to let you know that that actually there's some really interesting research that's coming out that I wasn't aware of until recently, that suggests that substance use disorder is, the way to go for different reasons. So that was kind of a long-winded response, Jennifer, but I kind of titrate, like, where do I think I can go with this person? And sometimes it's light touch and sometimes it's more direct. So hopefully that's helpful.
Yeah, and I think that in our previous Facebook Live too, we touched on that a little bit
Oh,
too,
good.
and said kind of what you were saying, where modeling that language is
Mhm.
really a nice way to do that, and also one way to show that you're an ally is to speak up when you hear it, because like
Mhm.
it can be really hard for the person who has that mental health condition to say something, because it feels like it's kind of outing them. And
Mhm.
when you don't have it and you can say, hey, this is kind of lower stakes to me, because I don't feel like it's going to say anything about me, in the same way that somebody who has it would. So
Absolutely. That's such a great point. Yeah, thanks for sharing that.
I don't see any more questions. So, and I know it's getting a little bit
Oh,
late. So I think, oh, wait, I have a comment, and I'm going to end question. Sorry, I'm trying to like read.
okay, yeah, you
You're
keep
like,
reading. Let me just
yeah,
comment, and let me just give the NAMI Delaware, while you read the question, a big thank you for sharing all of these terminology guidelines. Like, what great resources that have been shared. These are best of the best. So those UNA terminology guidelines are really phenomenal. So those are like the best that are out there. So thanks for sharing those. Um, and thank you also for sharing the time to change link for that intervention. There's lots of information about it available online, so that's also great to see for folks who are interested in that. Wes, did that give you time to read?
it did, yes, and there is a question in it.
Okay, great.
So, from Sue, in my past, I was stigmatized in a work setting by senior leaders. I hope it never happens again, but how would you suggest handling stigma at work? I was afraid to approach human resources.
Sue, thank you so much for sharing that. Thank you so much for sharing that. This is a big issue that folks face, and thanks for disclosing that here and for raising this, because I'm sure that this is either something that other folks who have experienced or are like worried about experiencing, right? So, um, I think I think that there are some options when this happens. One is an HR approach. I'm You are saying that you are afraid to approach human resources, but I think maybe it's worth saying for the broader audiences that there are protections in place, and so if we feel comfortable with it, approaching human resources can be helpful. I completely, though, want to say that I understand why you would be afraid to contact HR and nervous about that. So, depending on where you work, depending on what your HR group is like, I think that it's completely reasonable, though, that you wouldn't want to approach human resources. I have not approached human resources in the past when I've experienced sexism in the workplace, so we can all relate to that. So, um, I think that there's not knowing the context of the stigmatizing thing that happened. There's a few things that I think about kind of generally. One is, depending on what happened, I mean, there's the direct approach of talking to to the senior leader about what happened and trying to raise awareness. I have to say, if it were me, I can't imagine wanting to do that. But, depending on the size of your organization or who your senior leader is, there might be some room for an educational opportunity. Again, can't imagine that that's something that I would want to do. Um, Again, depending on the nature of the stigma of sort of what happened, I wonder if there's an opportunity for kind of more of a long-term game. So like we couldn't do like that incident happened and maybe I don't feel comfortable addressing it with my senior leader or with HR, but maybe I want to think more about my workplace culture or context. And so maybe what that looks like is an education or contact based like intervention for the workplace more generally. So saying, hey, holidays are tough. Folks are experiencing mental health struggles. Why don't we get folks from NAMI over here to give us a presentation on, mental health around the holidays? Or why don't we read something together or watch something together and like facilitate some discussion. So that doesn't help you with the incident that happened, but any sort of like education intervention that you can roll out in your workplace or any sort of contact-based intervention where folks are getting to know like the stories of or getting to interact with folks who have experienced mental illness might be helpful for preventing that to happen again or just sort of start changing the culture of the workplace. So that's another thing that comes to mind. And then Sue, I have to say, I'm always just worried about the person who experienced the stigma. And so we try in some of the work that we do to have sort of plans for when people are experiencing it until we can get to a place where it just doesn't happen. And so here's me being hopeful that you have good allies in your workplace, like friends that you can go and debrief about when this is happening, or therapists or other folks that you can connect with to talk through it, to just make sure that that negative experience that you had doesn't impact all of these things, doesn't make you feel more stressed in the workplace or lead to other things, given that we know that stigma can be so detrimental for people. So that's kind of a flurry of thoughts. Oh, and I'm seeing your response about liking the generalizing the discussion through education to try to lessen the likelihood that it'll happen again. So thank you so much for that feedback, that could be something we're thinking about.
Thank you so much, Valerie. Your responses are just amazing. I'm just in awe. You're so brilliant. And I'm so glad you're able to come and have this discussion with us tonight.
Thank you so much for having me, Wes. It's such a pleasure to facilitate this Q&A with you. And again, I just want to say what a huge, enormous fan of NAMI Delaware I am. The more that I learn about the great work that you do, the more impressed that I am. I mean, we could do like a whole stigma talk just featuring like, here's all of the great evidence-based stigma reduction stuff that NAMI does. And so we'll have to come back next time to do that.
We'll have to consider that.
Yeah, we'll do that one together. So
Yeah.
thank you.
Thank you. Yeah, I think we will wrap up now because
Great.
I think that is officially our last question. So thank you everybody who logged on to watch, or thank you from the past if you're watching later. And I hope everybody has a great evening and a great holiday season. Thank you.
Bye.